Well, how can you cram so much information into an hour and a half? It's almost an information overload, but I hope that you've all found something in there which has at least stimulated some thought and maybe some concern about the proposals before the States next week. We have a chance now, even though there's been so much information, if you still have a question, the speakers will be pleased to answer them. So if there are any questions from the floor, I'll be happy to take them. Just raise your hand and speak clearly enough for the people to hear them. Do I have any questions, please? Yes, right.
2 points, the heroic life of Stephen Hawking and the so-called Hippocratic Oath, which doctors take, that germane to the discussion.
Stephen Hawking and also the Hippocratic Oath.
Yeah, I mean, I think there are lots of examples like Stephen Hawking who, of people who have severe disabilities who achieve a lot in life, achieve things which most of us won't achieve, who have a fulfilling life. There was a case of two rugby players who had, one was called Daniel James, I can't remember the name of the other one, but anyway, they both had accidents playing rugby. One of them was depressed, went off to Dignitas, ended his life with the help of his parents. And the other one set up a charity to help young people learn to play rugby, and is a very fulfilling life, and so often same circumstances but just a different environment. And that's the issue about how we approach people with disabilities. It's the attitudes that we have and impart towards them that is often the problem. And the Hippocratic Oath, the Hippocratic Oath covers a range of things. Of course, it was introduced because euthanasia was a common practice, as were other things. But some of the other things in the Hippocratic Oath are that doctors shouldn't have sexual relationships with their patients, that doctors, that there has to be respect within the profession as well as professional standards, that junior doctors should respect their superiors and not think that they know more than their superiors do. All sorts of very common things that we would want to see protected. And I think perhaps the move away from the Hippocratic Oath in medicine has been underlying the potential shift in medical opinion on this issue in some jurisdictions.
Thank you, Gordon. Yes, lady over there.
I think I just want to sort of make a point about advance directives or lasting powers of attorney, where people make decisions about, I'm a nurse by background, where people make decisions about what they want in the future for their health. And I think also within that, we need to be a little bit careful, because it's very subjective. Quality of life changes. I worked for UCL in research, and quality of life often adjusts over periods of time. So people with, many chronic conditions or difficult conditions, when between the stirrup and the ground, actually feel that their quality of life might not be what they thought it would be when making advance directives. And I've worked extensively with people with dementia, looking at quality of life and comparing that with the quality of life that carers perceive the person has. And that often is very, very different. And people with dementia almost, always in my experience, perceive their quality of life as being very good. So I think we need to be very careful, when we're asking people to do things later on, and make that about sort of living well and not about how you want your life to end.
Thank you. Any speakers want to comment on that?
Well, I'm just reminded, because I agree, those are potentially very, very dangerous. I remember reminded of words of Baroness Warnock, who once said of those suffering from dementia, if you're demented, you're wasting people's lives and you're wasting the resources of the National Health Service. She actually went on to suggest that they indeed had the duty to die, and when she mentioned on the advance directives, she said, I think that's the way the future will go. Putting it rather brutally, you'd be licensing people to put others down. Mm-hmm. That's the intention of those who have really advocated for this kind of thing. And I think that's a really disturbing, and again, very ableist, but also quite ageist and quite subhuman attitude towards people who are in very vulnerable situations. So it's worth remembering that those attitudes exist. And I mean, she was very obvious and honest about that. But I think there are a number of people in the community who may have those kind of attitudes but not say them outwardly, but practice according to them. Unfortunately, we do see that. So that is definitely a concern to bear in mind.
I think what I would say about advanced directives is they don't just have to be about how they die. It's, as Jeanette says, it's about how you want to live in those years as well. So you can make comments about where you'd like to be cared for, what that should look like, you know, who you'd want to be involved in making decisions about your care. And so just by people having more awareness that they can have control over these factors that might make their lives feel more meaningful or hopeful at the end, by using some of the legislation that's available is just really valuable.
Yes, lady in the middle there.
Thank you, Dr. Bradley, for all that you've said. It's been very enlightening. I'm so sorry that the Commission didn't get to hear your point of view. I was nursing for 38 years, 21 years at the Cheshire Home with severely disabled people, many of the worst neurological diseases. In all that time, I can honestly say in all my nursing career, I never had a patient who said they wish they could be put down or they wish their life could be ended. They would like their lives to be made easier, certainly. But do we actually ever need this law? Because how many of your patients actually have tried suicide instead of asking someone else to euthanize them? In my, short experience or only experience, is that people don't go for suicide. Why do they have to expect society to do it for them? If its life is so bad. I mean, I know there is quite a bit of suicide over here with mental illness, or it's perceived to be that way, and mental illness and physical conditions can be quite separate in many ways. But it just seems so hopeless to have this up the law when it's not, it can't even be needed.
I think that's very true, and I think people's perceptions of those people's lives living in Cheshire Home would be very different from the actual reality of those people's lives, and that's what the problem is. What I would say is when I was working in the UK before I came here, I saw an increasing number of older people seeking to take their own lives for fear of the cost of care homes, for the fear that that would take away inheritance from their families. And my argument would be is that there's something wrong with society. It shouldn't be that people are resorting to these measures. We need to make society better, not give them the option of suicide.
Yes.
Just a couple of things, Dr. Ruddy. Just to clarify, I remember early on in your thing, I think you said that assuming one has capacity and you've got some sort of illness, you can refuse treatment and the doctor has to accept that. So then you rely on some sort of palliative care. And can one rely upon that palliative care? I know what you went on to say about palliative care. It's not necessarily quick and easy, but there must surely be a quick and easy way to smooth the passing. Surely.
Well, I think from what we've heard, I don't think there necessarily is a quick and easy way to smooth the passing. What I think people often fear is what they don't know and they've not experienced. And I think by having a really good relationship with the doctor who's treating you, with being able to talk about your fears, being able to think about how you want things to be, who you want to be around, how you want your life to end, can sometimes smooth that passing in ways other than using medication. I mean, I have had the sad experience in the UK of a lady came into hospital where I was working and she had written an advance directive. She didn't want any treatment if she had a stroke. And it was written at a time she had capacity. And in that situation, we got the legal team involved, but once we were sure it was right, we supported her wishes. She got palliative care, she didn't have treatment for her stroke, but she was supported not to experience pain, and she died a peaceful death.
And I think often with palliative care, people don't understand it, they don't know what's involved, and when they experience palliative care, often their perception changes. And certainly with my mother, who had cancer, she ended up in a surgical ward, and she was quite low in her mood, understandably. But once she was transferred to the hospice, she found the environment was completely different, and she said to me, "This place is wonderful," was how she described it to me. So it's important that people know more about palliative care and experience palliative care. And if my colleague Jo was here, she would be far better than me to explain to you what's involved in palliative. Maybe we'll send her over sometime to talk to you.
Is there a sort of definition or a range of palliative care? I mean, is there a beginning and an end to it? Is, a degree of it?
So they follow the gold standard framework here. I'm not an expert palliative care physician, so I'm not the person, but Carol Davis, who is the palliative care consultant, did speak at the Caritas lecture, which is available online, and so they would look at the level, how much life that person has left, and what are suitable interventions for the stage they're at, and just what's so valuable is the person being involved in being able to make decisions about that. I mean, I've got a friend I saw this last weekend. Her father had terminal cancer. They were fighting it for a long time, and he said he'd had enough. He wanted to have his dialysis withdrawn and be supported, and it could all be arranged. Because conversations can make things happen. But what I'm so worried about, we had an awful email, didn't we, from a palliative care consultant in New Zealand who has pointed out that since they've passed their bill for assisted dying, that, that there is no one in their parliament working on improving palliative care, but 40 people working on bringing in this euthanasia bill, and that for the cost of euthanasia, $1,000, that's it. Anyone in the country can see someone for euthanasia, but actually, I can't remember the percentage, but it was quite low about the percentage of New Zealanders who had access to really good palliative care, and they were really worried that this bill is going to stop things progressing. Now, Jersey Hospice is excellent. We are so fortunate here, but I think we could really look at how that's funded and how much states are supporting that. There is lots more we could do here. We do not have a ward for end-of-life care for dementia. We do, there are so many better things we could spend our money on here.
Well, I was going to actually ask if I can just ask another question, because you painted a sort of fairly dismal picture of what is available here, and that is quite scary, that we're in such a mess now, and are we going to be in a bigger mess with this hospital saga? So it doesn't give
I think people are aware of the problem we've got with this kind of high-level care for people with end-stage dementia, and I think it is being looked at. I think that's what we need to highlight these things, and we need people to look at them. But the hospital is absolutely needed, in my opinion. The hospital we've got is outdated. It's not fit for purpose. We cannot have the right things on site. We desperately need a new hospital to provide the right care into the future for our Jersey residents.
We need people to run it and run these departments to support people.
It's also worth noting that in Canada, a recent qualitative study interviewed physicians and nurses who were involved in palliative care in southern Ontario. And what it found was that those who were engaged in palliative care were actually afraid of engaging in symptom control, i.e. Reducing pain among certain patients, because the concern was that it would make them either drowsy or confused, therefore remove their eligibility for euthanasia. And this was causing not only problems but in terms of the relationship between doctors and patients, but it was of course meaning that those patients didn't get the pain control they needed. So in fact, euthanasia-assisted suicide, apart from anything else, actually retards palliative care development, and that's one of the other reasons why it should absolutely not be introduced into Jersey medical practice law.
You gentlemen here.
Two very quick questions. The first one's for Dr. Robbie. In regard to, you touched upon the subject of the depression as being number one. It can be very much interconcurrent with physical problems, with old age, with cancer, with other things. But it being underdiagnosed, undervalued perhaps, and subsequently undertreated. Are there any inroads in your how that can be improved, perhaps?
Yeah, so I mean, we've got exciting developments happening here in Jersey. They're funding us to do a proper liaison service to the hospital. We're waiting for accommodation for the team at the moment, so that we can be on site. This is part of the problem of our hospital at the moment. And we really do want to improve things. We want to work better between mental health and physical health. We want to help people spot these conditions. We want to treat them. And I think we have a real possibility of getting things right here. We have just recruited, quite a lot of substantive consultant psychiatrists to work here. We've recruited a lot of other staff. I think there were lots of, difficult things being said about mental health services at the moment, but I am optimistic that we can get to the right place.
Thank you. And just very quickly for Dr. McDonald, you mentioned on one of your slides something I've never heard of before, but prolonged sedation? Is that the term? And my question is specifically, is that a reference to sedation through opiates or another type of sedation, or just any type of sedation?
Yeah, it's continuous sedation until death. I mean, this happens sometimes towards the end of life in the UK. People would be, if particularly something was overly burdensome, some sort of intervention was overly burdensome or whatever. But in the UK, they use lower doses. The intention is not to kill, but to alleviate any symptoms. And they often use titration in the UK, so they would sort of ease people in and out of consciousness depending on how distressed they were, etc. What happens in the Netherlands is they use huge doses of opiates and other sedatives with the intention of ending the life of the patient and essentially put them in an induced coma, but don't actually end their life. They just put them in an induced coma and then allow them to sort of slowly pass away over a period of time. And that's what happened with my friend, whose father, I don't know if I mentioned this to you, but he got involved in this issue, this campaign on this issue, because his grandfather was in a care home. He had an infection in his leg. The care home invited the care home, they treated the infection with antibiotics, and then they called the doctor after they'd already started the treatment. And when the doctor came in, he said, well, the next time this happens, call me first. So the next time it happened, they called the doctor in first before starting on any treatment. The doctor then spoke to the wife and said, well, listen, he's there's really not much more we can do for him. And so they sedated him and they removed nutrition and hydration. And a week later, the rest of the family found out what was happening and objected, and so they started trying to feed him at that point, but he had deteriorated so much that he passed away. And that was what really motivated my friend Henk Reitsema to get involved on this issue of euthanasia in the Netherlands, because he saw what's been happening in terms of the whole medical practice there.
I'll take one last question, then have a last question to ask.
Can I just make a point?
Yes, sir.
The panel who was chosen to make decisions for our states.
Yes.
I put my name forward for it because I'm against euthanasia, but I wasn't chosen. And I heard subsequently that 80% of those panel people were in favour.
Yes.
83, beg pardon.
I think at the start of the process, 17 were in favour, and at the end, 18 were in favour out of the 23. So I'm told.
Yes, I think we could go on for a while about the constitution of that panel. But I think the general impression I get is that you shouldn't make laws like this based on the opinions of random jury of small number of people who are not necessarily experts. Whereas tonight we have had 3 experts, and I'm very grateful for the amount of information they've given us. In fact, I don't know, some of you may be suffering from indigestion from too much information. But I hope that you've found something in this evening's presentations which interest you and stimulate you, and maybe as a result of this evening, rather than just leaving tonight and saying, well, that was very interesting, and forgetting all about it, what can we do? I think first of all, there's 50 or 60 of us around the room tonight. Talk to your friends and neighbours, tell them what you heard tonight, and stimulate discussions. They may have different points of view, but at least let's get people understanding the breadth of the issues involved. The people who decide at the end of the day are going to be state members. And state members will listen to what you say if you tell them. So please, don't be afraid. Write to your state member, email them, phone them up. Not in the middle of the night, they mightn't appreciate it too much, but let them know what you're feeling, and encourage them to listen to these arguments as well. If you have found that there's so much information you can't take it all in, one of the purposes of tonight's meeting was to remind you of the 2 new websites which are going to be, which are now live. Yeah. If you've got a pencil and paper, the first one is called Care for Life, all one word, careforlife.je. The JE stands for journey, if you haven't guessed. And the second website is called Our Duty of Care, all one word, .je. Now, if you haven't got a pencil and paper, don't worry. Google, if you type Our Duty of Care, whether with spaces or not, even with a spelling mistake, you'll find it. Just persevere. I think before we go, we deserve to give our 3 speakers a further round of applause for all the information they've given us. And finally, can I thank you, ladies and gentlemen, for coming out this evening and listening and showing your interest in this very important subject. Thank you and good night.